Hello, I'm Susan Cole.
And I'm Vanessa Apea.
And welcome to Health and Power, the live monthly broadcast on health inequalities affecting people of colour and, crucially, steps we need to take to fix it.
Thank you, Susan. And today we have two wonderful guests. We have Dr. Rageshri Dhairyawan, who is a consultant in sexual health and HIV medicine at Barts Health NHS Trust. And she's also an honorary senior lecturer at Queen Mary University of London. And her clinical work, research and advocacy focus on improving health equity for marginalised populations, particularly at the intersection of ethnicity and gender. And Rageshri is currently the chair of the steering group of Forum Mentor Mothers and also a medical advisor to NAS. And she has previously held national positions at Bash and Beaver, most recently working on Beaver's EEDI review, looking at equality, diversity and inclusion. So really excited to have Rageshri here. And just to sneak in that our offices in London are just next door to each other. So no, it's great to speak to her in different capacities. We're really excited. And then we have Dr. Steven Okoli, who is a consultant at Hammersmith Hospital, Imperial College Healthcare, and he has a specialist interest in red cell disorders. And his main area of practice is in the fields of sickle cell disease and rare anemias. And he's the subspecialty lead for the Northwest London local clinical research network and the principal investigator for several clinical studies in red cell disorders. And he's also actually the adult stem cell transplant lead for sickle cell at Imperial. And amongst all his other activities, he's an honorary senior clinical lecturer at Imperial, but also he leads the Imperial College Sickle Cell Group and is medical advisor for the African Caribbean Leukemia Trust. So as ever, Susan, we are very, very fortunate to have wonderful guests.
Absolutely, very excited to have them both on, and it's great to see you. I know I saw you very, very briefly in Warsaw. Yeah, we were both speaking at different HIV conferences on Warsaw, so we bumped into each other. But even though it was a focus on HIV, in the talk that I was doing, I talked a little bit about the health inequities that Black women with HIV face. And very often, HIV is just a really small part of people's lives. It's all the other intersecting forms of stigma, discrimination, and disadvantage that's causing the problem. So we can't really find solutions unless we really consider intersectionality.
Completely, Susan. And when I was in Warsaw, I was co-chairing with the wonderful Magda the European Stigma and Discrimination Forum. And exactly as you said, that sentiment of HIV being so small in people's lives, but it's the wraparound issues and that wraparound stigma that really dictates whether they live their best life, whether they thrive, or whether they really, suffer in silence. And so it was a really powerful meeting, actually, but really emphasizing everything you said.
Brilliant. Well, if only we had someone who was a specialist in this area that we could bring on as a guest.
I love our links. Yeah.
Hi, Rageshri.
Hi both. Lovely to see you. Thank you for inviting me on.
Wonderful. It's brilliant to have you on. And Rageshri, when people think about health inequalities in HIV, very often the focus is on the inequities between countries. But actually, you've done really important work to demonstrate the inequity within countries and different outcomes facing people, particularly from racially minoritized communities. Can you tell us a little bit about your research?
Thank you, Susan, for saying that. Yes, so I think my research was really guided by what I was seeing day to day on the wards and in clinics. I work in East London, which is a very unequal area when it comes to socioeconomic status, for example. So what we were seeing on the wards were that people were being admitted with advanced HIV, and they tended to be people who were racially minoritized. So my research really stemmed from that, and I collaborated with colleagues on UK Chic to look at the HIV care cascade for people of colour, finding that people of colour were more likely to be diagnosed late and more likely to have viral rebound and not be in care. Also did some research in the PRIME study, looking at the data there, showing that older Black women were more likely to suffer from psychological distress and less likely to be on treatment for it, more likely to live in poverty. So it's been important for me to show that these inequities are also in this country as well as between countries.
It's so important, and I think that the work that you've done in terms of really zooming in on different populations has been crucially important. And I know that an area that's really important to you as well is looking at the experiences of people of South Asian ethnicity and looking specifically at sexual health and HIV. And I just wondered if you could just talk us through that, because I know that you did some work very recently about that.
Yeah, obviously I'm South Asian myself. I'm of Indian descent, and I work in Whitechapel. There's lots of South Asians in Whitechapel, and I just noticed there was a real lack of research on this group. South Asians are actually the largest ethnic minority group in England, but there's very little data on them when it comes to HIV and not much on sexual health. So I wanted to fill this gap, and I sat in on panels where people asked me for data, and I said, there is no data. From the data we know that when it comes to HIV, South Asians are often presenting late and being diagnosed when they're symptomatic. And the recent research study I did was looking at national STI data from the GumCAD dataset. And this was looking at bacterial STIs amongst South Asians in England in 2019. And the results weren't very surprising. We found that, they were more likely to be diagnosed in gay and bisexual MSM. In young people, there was a link to poverty. There was a link to kind of where people lived. So, for example, people in London may be more likely to be diagnosed with an STI. This was not surprising data, but it just didn't exist for South Asians. So I think it raises questions about the future work that we need to do to reduce barriers for South Asians to use sexual health services and to get earlier HIV testing.
Completely.
Right. Thank you. Yeah, a very important area, and something that comes up quite a lot in discussions that I have with people of colour across disease areas is, particularly in terms of women, is when we go to the hospital and we speak about our symptoms or we speak about our pain, we're not believed or we're silenced, and that can have a really harrowing impact on people really widely. I mean, you've done some research and are actually writing a book on this issue. Can you tell us, what you found?
Yeah, absolutely. So I am writing a book. It's out hopefully in August next year. That's all I can say at the moment. It will be officially announced soon. So the book is based on my experiences of being a patient where I was denied pain relief. This was a long time ago, but I noticed that I didn't really talk about it for years and years. I felt quite silenced by it. I didn't complain. And then I thought to myself, if this could happen to me, and I was a consultant at the time and knew how the NHS worked, what on earth happens to everybody else? So this really made me think about who gets heard and who doesn't in healthcare and what we can do about it. So the book is looking at this from like a patient-doctor level, thinking about why doctors don't listen to patients, but also how it works on a wider level. So, for example, we know minoritized doctors aren't listened to by their colleagues, and they will often advocate for their patient groups. Same with minoritized researchers, and that lack of research leads to data gaps. And also silencing at a bigger level in global health as well, thinking about researchers and communities that don't get listened to in the global south. So the book is really looking at how we can address this. I think people always say, you should speak up, but we know that people find it very difficult to speak up. There's lots of barriers to this. So the real kind of aim of the book is to look at how healthcare itself can change so that we are better at listening to all patients. And so we provide good empathic healthcare to everybody.
Oh, thank you so much, Rageshri. We feel very honoured because we've had an early sneak peek discussion with you, and we're really looking forward to seeing it come out. And I think one of the things that you've been doing in your work is about centering voices. So, you know, centering those of South Asian ethnicity and trying to look into their experiences. And it's really important on the patient level and the doctor level, but also on the policy level as well. I know that you've been involved in BEVA, which I said earlier, which is the British HIV Association's Equality, Diversity and Inclusion Review, which has been, it's such an important process. And I just wondered if you could give us just a snapshot of the work that was done in that.
So first of all, I want to say kudos to BEVA for doing this work, because it takes a lot of courage, I think, to look at your own organisation and to see where you're lacking. So well done to BEVA. The work was initiated by my colleague Tristan Barber around the time of COVID, who saw that other organisations were also doing these reviews. And he approached me, and together we approached the BEVA board and the BEVA chair, who agreed this was important work, and got us the funding to be able to get an independent company, Purple Pen, to actually carry out the research. And it was very important for us that we looked at kind of all aspects of EDI, so not just thinking about some things, but thinking, for example, about people who work less than full time. How can we make BEVA better for them? We wanted to include not just BEVA members, but also HIV community voices as well. So thinking again, how can we make sure everyone is heard? And I think it's important. So from that review, which we presented the results at the conference, and the results are online on the BEVA website at the moment, we are convening a working group, and we're looking for people to come and help us do that. So if you have strong views about this, then come and join us and we can do that work together. But I just want to add that I think last week we heard that our health secretary had asked NHS trusts to stop employing EDI professionals. So there's a real pushback on EDI at the moment. And I think when people talk about EDI, they say it's the gold standard thing. So we need to get the basics right. But I think getting the basics right is EDI. I think if we get care right for the most marginalised, most minoritized communities, then we are getting care right for everyone. So yeah, that's my stance around EDI. Very passionate.
Thank you so much for saying that, because I was reading about that again today, and it's so painful because we have so much to do, and we need to have the right resources in place to facilitate that and embed it so it comes in our, you know, naturally in our day-to-day life. But unfortunately at the moment it doesn't. So thank you so much. Oh,
thank you.
Yeah. And thank you for everything that you're doing as well. You're a real source of inspiration to people in the community living with HIV.
Oh, thank you.
Thank you. Yeah. Wow. Yeah, absolutely brilliant to have Rageshri on. And I know that there are quite a few people in the community watching today, particularly because she was coming on, and everyone's really keen to hear what she has to say. And I know at the minute, you know, this month it's Black History Month, and the focus is saluting our sisters. And I think it's really pertinent as well, just thinking about the community of women living with HIV who are doing so much, but so infrequently recognized. And some close friends of ours have written a book, our stories told by us, celebrating the African contribution to the UK HIV response. So it's like a big shout out to Angelina, Memory, Winnie, Rebecca, and Charity, who've written the book. And I think one thing they really wanted to get across is the fact that, you know, when we often talk about Black women with HIV, presented as passive, voiceless victims, but this book actually bazookas those tired tropes and actually shows the really important role that Black women living with HIV are playing in the HIV response.
Oh, completely, Susan. And it's wonderful to be able to salute them, because it's a fantastic book, and it challenges, as you say, perceptions and mindsets, and just shows how people have empowered themselves and then empowered others, so they paid it forward as well, and that's something really important. And I know for me, reading the book, I just loved it because there was as you say, there are friends and there's so much more to their lives that I just didn't know, and so we got to hear about their full backgrounds and then their journeys, and I felt really honored to be given a lens into their lives. So yes, completely saluting our sisters there and putting it out there that our stories told by us is on Amazon, and it's a fantastic.
Absolutely, and you and I have written a little bit in that book as well. Shameless plug.
Plugging ourselves as well, but no, it's a fantastic book and beautifully curated and has some really powerful perspectives in there. So yes, very proud of them.
Brilliant. So shall we bring on our next guest?
Yes, Steven.
Hi. Thanks for inviting me.
Oh, you're very welcome, Steven. I'll put it candidly out there for everyone that I have been chasing Steven for many months to come on. So I am so happy, and he has been so kind, every chase, and he's come. So thank you so much. It's fantastic to have you here.
It's my absolute pleasure.
Well, Steven, one of the things that I've known about your work is obviously your work in sickle cell anemia, and we were really fortunate to have a powerful sickle cell advocate, Jen, who came on a couple of months ago and really gave her perspective and description of sickle cell. But just wondered if from your perspective, just to give us an outline, an overview of sickle cell, and perhaps also about those that are affected as well.
So sickle cell disease is an inherited disorder that is characterized by the formation of abnormal red blood cells. Now, when these red blood cells form, they don't have the flexibility that a normal red blood cell will have. So they end up blocking the small blood vessels. And what can also happen is that these red cells can break down. Mm-hmm. The consequence of this is that beyond that blockage, the blood supply to the tissues is impaired. And the cells that break down release effective toxins that give rise to quite a diverse sort of group of symptoms. Mm. These include, and which is what most patients will present with, is pain. And this pain is excruciating. Pain that some patients have described as worse than childbirth, that is like being run over by a bus, this sort of pain. But not only that, it will also affect anything that has a blood supply, so every single organ imaginable. And is unfortunately life-shortening. So we know that sickle cell patients have a life expectancy of more than 20 years lower than their ethnically matched peers. And it's quite sad. The treatment options are quite limited. Blood transfusions and a drug that's been repurposed for sickle cell disease, hydroxycarbamide, hydroxyurea. And as a consequence, sickle cell patients have a raw deal. Mm. They're offered pain relief, but with one hand, but with the other hand, they're told that that as a consequence of the use of pain relief to manage their symptoms, they're told that they're often sort of labeled as addicts, as drug seekers. Mm. And it's a very hard life. I've met a lot of sickle cell patients in my time, and the vast majority are very intelligent, very sort of focused people that if they had better chances in life, would have been able to make more. Some do. Don't get me wrong. A significant proportion of our patients that manage to do well with sickle cell disease. They cope, they adapt. But a significant number, unfortunately, the disease defines them and limits their ability to achieve.
Right. Thank you so much, Steven. And that was very much what we heard from Jenica, just in terms of the absolutely excruciating pain, but at the same time going to the hospital and not actually being believed, which is just absolutely appalling. I know in terms of red cell disorders, there's quite a lot of focus on sickle cell, but are there other conditions you think it would be helpful for people to know about?
So there are. So just to quickly, to go back to your point about focus on sickle, there has been a massive increase in focus. When I started as sickle cell doctor a long time ago, there was very little in the way of focus. Sickle cell disease was a forgotten disease. I think there were several things that have changed that. Not least unfortunate deaths within sickle cell disease, particularly sort of Evan Nathan Smith, who unfortunately died in hospital, calling an ambulance while he was in his hospital bed, and that led to the all-party parliamentary group report, which I think had led to a sea change in the way in which we manage sickle cell patients, because there's more money being channeled towards sickle cell disease, and pharmaceuticals companies are now looking to develop new treatments. But to answer the second part to answer your question, to be perfectly honest, there were several disorders. I did my primary research was in GCSPD deficiency, a disorder where you have reduction in one of the enzymes important to the formation to the function of the red cell. It's one of the most common disorders known to man. 500 to 600 million people in the world are affected. Thankfully, the vast majority of patients or people that are affected never know. But it's a disorder that can be precipitated, can be brought on by stressors, so infection, hydration, pregnancy, certain foods, drugs. And this, similar to sickle cell disease, gives rise to a breakdown of blood cells and the consequences of that. Now, unfortunately, like sickle cell disease, there were no treatments for it at the moment. There were no treatment options other than supportive care. So seeing patients through their crisis and then educating them so that they avoid the things that could potentially trigger a crisis from happening again. And it's the same story, really, is that all of these disorders, sickle cell disease affects about 17,000 people within the UK. I just told you the number of patients, the number of people affected by GCSPD deficiency. These aren't rare disorders, but unfortunately, there aren't the treatments available to try to combat them directly. So we often use sort of drugs to manage symptoms, but we don't really address the underlying problem. And I think that's an important fact that hopefully over the next few years, we'll develop better treatments for both these.
Thank you, Steven. And I also want to thank you about your description of sickle cell, because you know, and the pain, because I've got family members who have sickle cell, and I have it ingrained in my mind, seeing them in a crisis and just seeing it's a pain that is really, as you say, really indescribable. And so when you hear about, and actually I've witnessed going with one of my cousins to go and seek help and not getting the help that they need and being really vilified for it. Sometimes really overtly and sometimes subtly, which I think, actually can sometimes be far worse. So really, thank you for really emphasizing that. But I know another part of your life is working with the Leukemia Trust and the Afro-Caribbean Leukemia Trust, which again has had such an impact on our communities in sense of just raising awareness and thinking about stem cell transplants and donations in general. Could you just give us a bit of insight into your work with the organization and what they're driving?
Sorry for interrupting. I was just so excited about it. I think the African Caribbean Leukemia Trust are an excellent organization. Sort of set up about 20 years ago by the parents of a young boy who unfortunately succumbed to an acute leukemia. They tried for decades, the Gales tried for decades not decades, for years to try and find a stem cell match. But because their son was of an ethnic minority, it was difficult. They finally did find a match, but unfortunately he succumbed to complications of the transplant. And their work highlights several important points. The first is probably the need for us to educate in general, not about specifically about transplant, not even about blood donation, which is both things are vitally important, but about these disorders like sickle cell disease. There's a lot of stigma. I'm Nigerian in origin. There's a lot of stigma, and historically for millennia. If you go back and look through the historical literature, you can see that there is a stigma that's gone for decades or millennia about sickle cell disease and how sickle cell disease is associated with spirits and all this sort of stuff. So trying to address some of those things so people feel comfortable at talking about the fact they have sickle cell disease. But also going into schools, going into all sorts of organizations, seeing people in their natural habitats and trying to encourage them to donate, particularly those of ethnic minorities, donating blood. So, as I alluded to earlier, sickle cell disease, one of the only real treatments is transfusions, blood transfusions. And having ethnically matched blood is vitally important to reduce complications associated with those transfusions. So having more patients of ethnic minorities, Black and African and Caribbean descent, donating blood means that blood is safer to the recipient. And also donating tissue. So we have, over the last, just before the pandemic, actually, in 2019, commissions finally allowed us to transplant patients with sickle cell disease and offer them a cure. But that is incumbent on people donating stem cells, the place where the red cells generate from, to them donating so that people can receive those stem cells and have that cure. Now, it's slightly, I won't bore you with the details, but at the moment we're only allowed to transplant those patients from a sibling. But the hope is at some point that we will be able to do to be able to expand that, to do transplants for unrelated donors, and having a tissue bank, a bank of people who are willing to donate tissue, blood, stem cells, kidneys, all these sorts of things, will mean that patients of African and Caribbean descent will therefore have better opportunities to live a normal life, because that's the aim, that's the goal. And you'll never see a sickle cell patient who doesn't say that they don't want to be cured of their disease. So giving them that opportunity is life-changing, life-saving. So it's really, really important.
Fantastic. That's very exciting in terms of those developments. And we're running out of time, but I just want to ask one quick question. Steven, what changes would you like to see in the treatment and care of people with sickle cell?
So, very good question. So a few things, I'll try and run through them really quickly. So first, I think it's really important that actually give the NHS commissioners their dues. They've listened and they've tried to improve the situation. So try to bypass A&Es. I think patients coming to dedicated sickle A&Es, places where they can receive analgesia quickly, be managed by clinicians and nurses that understand sickle cell disease, and they have relatively easy access is really important. So that's one of the great things that they're doing. I think engaging pharma to develop better drugs for sickle cell disease. We're getting there. There are loads of active clinical trials. We run quite a few of the Hammersmith, but we're not there yet. And education and educating, sort of, I think one thing that I'm trying to do is to sort of foster links with vocational organizations like Sickle Cell Society, ACLT, and various other organizations to improve education across the board. And I probably need to leave it there because I'm conscious of time.
Brilliant. Thank you.
Oh, Steven, thank you so much. And I especially just listening to the developments as well within sickle cell, which I think are really amazing, and just really hoping that things can move forward. But thank you so much for persevering with me and coming on.
Yeah.
Honestly, it's been an absolute pleasure. Thank you.
Oh,
lovely. Thank you so much. Oh my goodness. And looks like we are out of time. It just goes so quickly. I'd like to say a huge thank you to Rageshri and Steven for coming on, to Disruptive Live for their technical wizardry and making all of this happen, and to the lottery, without whose support we wouldn't be able to do this. So thank you.
Thank you. And really looking forward, as ever, to our next episode, which is on Monday, the 20th of November, again at 5:30 live. And one of our guests is Dr. Wanda Waporska, who is the CEO of the Black Equity Organization. So really excited. So thank you all so much for coming on.
Fantastic. And I'd also say to people who are watching, if you have been enjoying the series, or if you have any feedback, do please let us know. So thank you all, and we will see you next month.
Perfect. Bye-bye.
Thanks, and thank you, Vanessa.
Thank you, Susan.
All right. Thanks, everyone. Bye-bye.